Hello, everyone. Welcome to this webinar on trimesters of pregnancy with type 1 diabetes from PDC Mums and Bumps. My name is Caitlin Parker. I'm an accredited practicing dietitian, a credentialed diabetes educator, and I live with type 1 diabetes. I've gone through pregnancy 2 times with diabetes. So this presentation is obviously based on the guidelines as well as a little bit of my personal experience thrown in there too. So today we'll be working through a few different things. We'll be covering target blood sugar ranges, typical insulin uses and blood glucose patterns, general diabetes, general and diabetes specific appointments, scans and tests, to-do lists, and things to look out for that could be assigned to seek medical advice for each of the trimesters. The aim of this one is to give you a bit of an overview about what to expect throughout pregnancy. Of course, we include the disclaimer: the information presented is general in nature. Everybody and every pregnancy is different, so use this as a general guide of what to expect. As with all things related to diabetes, you could be the exception to the norm. It's important to consult with your healthcare team about your individual circumstances. So talking about insulin during pregnancy, insulin doesn't actually cross the placenta. Your baby makes their own. So there's no need to worry about the insulin that you administer harming your baby. The placenta acts as a filter and doesn't let the insulin through to your baby's system. One of the main bodies that we refer to during this pregnancy is ADIPS, or Australian Diabetes in Pregnancy Society, and they have all sorts of different guidelines for pregnancy. So they have come up with these blood glucose target ranges. So we are still aiming for 70% time in range as we are not during pregnancy, but the target range changes from 4 to 10 to 3.5 to 7.8. So the target range is narrower and lower. We're aiming for fasting blood sugar levels to be less than 5 millimoles per litre. If you're testing or checking your blood sugar levels 1 hour after eating, we're aiming for this to be 5.5 to 7.8. And 2 hours after eating, we're aiming for it to be between 5 and 6.7. We're aiming for our variance in blood sugar levels to be less than 36%, and we'll talk about this a little bit more on the next slide. We talk about these blood sugar targets as if this is kind of like easy to achieve or what everyone should be aiming to, but it really is the gold standard. So blood sugar targets should still be individual. We want to try and stick within these targets as much as we can without too many hypos. So your team may actually set different targets for you to try and avoid the hypos. Our percent CB, or our blood sugar variance, this is a number that kind of summarizes how much variation you have in your blood sugar level. So a high percent CB is where you have lots of changes in your blood sugar. You've got a bit of a yo-yo effect, so up and down, up and down. Moderate percent CB is where it is happening to much less of an extent. And a low percent CV is where your blood sugar level is flatter or more stable. So if we're looking at HbA1c, or our 3 monthly average, an average blood sugar level of 7% could look like all of these different things. But if we also look at the percent CV, it gives us a bit more of an idea about how the blood sugar levels are going. Starting off talking about conception. So the weeks of pregnancy are calculated from our last menstrual period. So you're not technically pregnant until 2 weeks gestation. By the time you've missed a period, you're typically around 4 weeks. Most people find out they're pregnant between 4 to 6 weeks, and this is where you may start to notice some instability in your blood sugar levels. There is a plethora of physical and hormonal changes happening, which can make diabetes management more difficult. So just be prepared to adjust your doses regularly. It can become as often as every few days, but you'll have a whole healthcare team behind you that's helping you to do this. So you find out you're pregnant. Now what? So our first steps are booking in with your GP, and they will do a blood test to confirm pregnancy, as well as check your HbA1c, your thyroid levels, as well as a few other things. They will create or document an estimated due date based on our last menstrual period. And they will also refer you for a dating scan to happen between about 7 and 8 weeks. They can do a medication review to make sure that all of the medications you're taking now are safe for you to continue taking during pregnancy. And they can discuss care options and make the relevant referrals. In terms of a diabetes review, so we want to check blood glucose levels and insulin requirements. We want to review our hypo prevention and treatment plan and also our sick day management plan. So your to-do list is book in with your GP, touch base with your usual diabetes team, check your recency of your complications screening, so your eyes, your kidneys, and your nerve function, and keep taking that high dose folic acid supplement. What to expect from your diabetes team. So, regardless of whether you choose to go public or private, your team will start contacting you weekly from around 8 weeks gestation. They will review your CGM data and suggest adjustments to your insulin settings. And this could happen through telehealth, except for the weeks when you have an in-person appointment. Always contact your team if you notice any significant changes in your insulin needs or blood sugar levels, because this can indicate that something is happening with your placenta. Our first trimester is 0 to 12 weeks, and this is a huge time for development for your baby. So we've got organs and body parts forming and starting to function. Blood glucose level control is important here so that these processes can take place with less risk. Your umbilical cord and placenta is developing, and this is where some people may experience unpleasant symptoms, which can make diabetes management more difficult. So, vomiting, nausea, food aversion, and fatigue. You may experience morning sickness, and this usually is worse in the first 12 to 14 weeks. There are some things that you can do to try and help. So we can try and avoid fatty, rich, or strong smelling foods, as these often make nausea worse. Eat slowly. Have small, frequent meals, as being hungry can sometimes make the nausea worse. Have crackers or toast first thing in the morning, sometimes even before you get out of bed. Keep up fluids, so sip on things like lemonade or cordial, because this can be full sugar or diet depending on what you need. And things like icy poles, again, full sugar or diet depending on what we need. Contact your doctor if your nausea is becoming unmanageable, because there are medications that can be described to help. We want to aim um, for our diet to be as nutritious as possible, and this can be very hard if you can't eat anything. With ketones or diabetic ketoacidosis, DKA, this is something that we want to avoid during pregnancy. So if there's not enough insulin in your body for your cells to be able to use glucose for energy, your body will break down fat instead. DKA occurs when ketones change the acidity of your blood, impacting the way that your organs function, and it's very dangerous for you and your baby during pregnancy. Dehydration or change in blood acidity can prevent adequate oxygen from reaching the baby. Don't stress too much if the ketones are a one-off event. The impact depends on how often it's happening, the severity, and the duration of each episode. So we've got fat breakdown, which then goes to ketone formation, which is the potential for DKA. So Early treatment of ketones is important. Always check for ketones when your blood sugar levels are persistently high or you feel unwell or you're symptomatic for ketones. In pregnancy, ketones can present even when blood sugar levels are in the target range, so it's important to test if you feel any of those symptoms. Managing ketones, so having a plan for managing ketones is summarized in your sick day plan. So we want to use ketone strips, which is our preferred option, or urine test strips, which are not as accurate, to check for ketones. And we want to make sure that these are in date. Seek urgent medical care if ketones are present or if you're experiencing nausea where you can't keep down fluids. Always take your basal and or your long-acting insulin, even if you're unwell, because this lack of insulin is what causes ketones. If your blood sugar level is dropping too low too often, do things like sip full sugar drinks so that you can help to maintain your blood sugar levels. On your to-do list are updating your sick day plan, stocking up on things like hydrolyte and lemonade, checking the expiry date and stocking up on ketone strips, and checking blood sugar levels and ketones regularly when you're feeling unwell. This picture you'll see a couple of times during this presentation, and it's a bit of a summary about what's going on in your body in terms of the insulin resistance. So along the bottom, we've got weeks of pregnancy, and along the side, we've got levels of insulin. So this kind of indicates our insulin resistance. In the first 6 to 8 weeks, the blood sugar levels may become more unstable as our insulin sensitivity increases. We become more sensitive to insulin. The insulin requirements generally are lower until about 16 to 18 weeks. Severe hypos are more common in this time, especially between about 7 to 12 weeks. Hypos haven't been shown to cause fetal harm, but they can be dangerous for your own safety. So some of the causes of hypos can be trying to improve control too quickly. So bringing your blood sugar levels down because you found out that you're pregnant. It can be due to nausea and vomiting and not really feeling like eating, or those hormonal changes. The symptoms might change of your low blood sugar, so you might not realize you're low until it's severe. And if you're spending more time at a lower blood sugar level, we've got an increased risk of unawareness. So your jobs are to check that your glucagon is in date, educate your partner or family on emergency hypo treatments, including how to use your glucagon injection, and stocking up on a variety of hypo snacks. Sometimes your go-to snacks might not be quite what you're feeling like, so having a different option can be handy too. With treating our low blood sugar, so what we want to try and do is not to overtreat hypos so that we get the rebound high. For our MDI, multiple daily injections, or our pump in manual mode, it's the 15-15 rule. So 15 grams of a quick-acting carbohydrate, wait for 15 minutes, and then repeat this if your blood sugar level is still low. The hybrid closed loop pumps have specific recommendations on how much sugar to have when you're having a low blood sugar. And this is because the pump is working in the background before you're low to try and prevent that low. So it might be reducing your insulin during that time. So Ipso pump, they recommend 7 to 8 grams of carbohydrate, wait 15 minutes, and then repeat if blood sugar is still low. Medtronic, say 5 to 10 grams. T-Slim recommend 8 to 10 grams, and Omnipod, it's 15 grams, but some people find that they need less. Be particularly careful if you've got another child at home because chasing after older children can increase that physical activity, which can increase risk of hypos. Exercise in pregnancy. So lots and lots of benefits of staying active. It can help with our blood glucose control. It can help with managing pregnancy symptoms. It can help to build up our stamina for birth and can also improve our mental well-being. The goal is to simply maintain our fitness, not start anything new. If we're looking at the physical activity guidelines, we're aiming for 30 minutes of moderate intensity physical activity each day, even if it's split up in chunks. So it could be a 10-minute walk, 10 minutes of prenatal strength workout, and a 10-minute walk across the day. To manage exercise during pregnancy, we want to check our blood sugar levels regularly. So before, during, and after. We want to stay hydrated and make sure that we've got hypo snacks ready. Avoid overheating, so dress to suit the conditions. Don't exercise if you're unwell, have ketones, have a temperature, or you are hungry, and consider the effect of different types of exercise on your blood sugar levels and adjust your strategies around that. The scans that we have during the first trimester. So we've got our routine pregnancy checks. A dating scan usually happens between 6 to 8 weeks. We've got a full blood screen, so your GP will ensure you get exactly what you need. NIPT or NT blood tests and scans. The NIPT is a blood test to screen for chromosomal abnormalities and also shows the baby's sex or gender. NT is a blood test combined with an ultrasound to assess the risk of chromosomal abnormalities. Your diabetes special tests. So we're looking at HbA1c testing and we're aiming for it to be less than 6.5% without too many hypos. They'll do a thyroid screening and a baseline complication screening if it's not been done recently. Other first trimester to-dos. So chat to a dietitian about safe foods if you have nausea, um, especially if it's getting in the way of you eating a balanced diet. Speak to your doctor about medication to manage nausea if it's becoming unmanageable, and submit your paperwork to access your fully subsidized CGM if you've not already done it. Moving on to our second trimester. So this is weeks 13 to 27. Most people report this as being the most enjoyable trimester. So you'll start to feel your baby to move. The umbilical cord is fully developed at 16 weeks, and this is when most people's insulin needs start ramping up. We've got our graph showing insulin resistance again. So right here in the middle, you can see that the amount of insulin that we need is starting to increase, and it will continue to increase as we get towards the end of our pregnancy. The insulin needs rise progressively from 16 to 36 weeks, but especially after 18 weeks. Your bolus and your correction doses usually increase the most, while your basal might only increase slightly. The reason why this changes is that the placenta makes hormones which interfere with how insulin works. So as these pregnancy hormones rise, so do the insulin needs. You might find that one of the management strategies that works well for you is a longer pre-bolus, so giving your insulin before your meal, as well as going for a short walk after eating. This can help to dull those post-meal spikes. If this is not your first pregnancy and you have older children, you might find that your insulin needs don't rise as dramatically as they did with your first pregnancy. And this could be because you're moving a bit more, looking after your older children, especially if they're active. And you may have also had a change in work situation, which may mean that you're generally more active day to day. Our second trimester tests and scans. So our routine tests are the 20-week anatomy scan, and this is where you can find out the gender if you choose to, if you've not had the NIPT test. And you may get other blood tests depending on your risk factors and your team's guidance. Your diabetes special checks. So there's an emphasis on checking the cardiac anatomy or your heart during the 20-week scan, And it's because babies of women with type 1 diabetes are at a slightly higher risk of heart malformations. You'll get growth scans from 24 to 28 weeks, and the frequency depends on your risk factors. You may have HbA1c testing done, and the target changes to less than 6%. This is because during pregnancy, we have an increased red blood cell production turnover, which means that HbA1c will be lower with the same blood glucose levels. At each antenatal appointment, they'll do a urine dipstick test, and this is to test for protein leakage or the presence of infection. A small amount of protein in the urine is not uncommon during pregnancy, but a larger amount can indicate kidney issues or preeclampsia. They'll also do a weight check, and this is usually to monitor for things like swelling. If there's a rapid increase in your weight, it could indicate a risk factor for preeclampsia. And then they will also look at your blood pressure again to check for preeclampsia. We want to make sure that we look after our mental health. So, for most people, pregnancy planning and pregnancy itself is one of the most challenging times for our diabetes management. So, achieving these pregnancy blood glucose targets, as we said, they're tighter and lower. It requires a lot of work and a lot of collaboration with healthcare professionals, which can be overwhelming. It's really common to feel guilty or anxious about how your blood sugar fluctuations will affect your baby, but try to be gentle with yourself. Make sure you talk to your loved ones about how you're feeling and how they can support you, and reach out for professional help sooner rather than later. Our third trimester, so this is 28 weeks until birth. The baby is growing, developing fat, practicing movements and reflexes. This is where you may experience fatigue and digestive issues. Movement can become more difficult, and swelling is common but should not go unchecked. The last piece of our graph shows you that we continue to have a rise in our insulin requirements, and we tend to have a steep increase between about 28 to 32 weeks. It starts to plateau from about 34 weeks onwards. And sometimes a small reduction in insulin is common here. By around 30 weeks, you may be taking 2 or 3 more times more insulin than you were pre-pregnancy, and you may need to further extend your pre-boluses, so have them earlier than you would normally do. Post-meal walks become really helpful at this point. We said as a small decrease in insulin can be normal in the last few weeks of pregnancy, but we want you to contact the hospital immediately if you notice a more significant decrease in your insulin requirements, or you're experiencing more hypos than usual, as this can indicate that your placenta is not functioning as it should be. Again, check in if there are any changes in your regular fetal movements, and it's always best to get checked if you have any concerns. Our third trimester tests and scans. Our routine ones are continuation of the routine tests at each antenatal appointment, including urine tests, blood pressure, and weight. Our diabetes special ones, again, if you get your HbA1c checked, we're aiming for less than 6%. You may have a growth scan every 2 to 4 weeks, measuring the estimated weight, height, head, and torso circumference, as well as amniotic fluid. A CTG may be recommended from 34 weeks, which measures the baby's heart rate and fluctuations, as well as your uterine contractions. These usually take around 30 minutes, depending on your baby's activity levels, and typically once or twice per week until birth. We've mentioned a couple of times this preeclampsia. So this is new or worsening high blood pressure and protein in the urine. It's high risk for both the mother and the baby. We've got a higher risk of developing preeclampsia if you have pre-existing retinopathy, so changes in your eye blood vessels, or nephropathy, so changes in your kidney blood vessels. There's currently no effective treatments for preeclampsia except birthing the placenta. Prevention is the key. So your healthcare team may advise you to take a low dose aspirin or a calcium supplement to try to prevent preeclampsia, but the research is still emerging about the effectiveness of these interventions. Your to-do list. So you might like to borrow an at-home blood pressure monitor in the third trimester so you can check your blood pressure levels at home and catch any changes early. Our third trimester discussions, so birth. So diabetes management is a very important part of your birth plan. We want to allocate roles for support people, discuss insulin settings with our healthcare team for labour as well as immediately postpartum, and discuss diabetes technology with our medical team. So this can include things like our site placement and swapping to a plastic cannula. There will be multidisciplinary input for planning of the time and mode of birth. And you can ask and discuss about what care for your baby will look like if they need extra care after birth. Postpartum, your healthcare team will discuss a contraception plan with you. You can take actions to protect your mental health. So this can include setting up support networks and accessing services if you need them. You will need to have a plan in place for your insulin settings post-birth, including timing of those changes, as well as whose responsibility it will be to remind you. Your insulin requirements drop dramatically as soon as the placenta is out. And because of this, it's important to have a plan in place. Discuss the effect of breastfeeding on your blood glucose levels and your insulin sensitivity with your healthcare team, and review your diabetes management plan for breastfeeding if you choose to breastfeed. Preparing for birth. So we want to ensure that our support people know where the hypo treatments and the spare supplies are. Pack your hospital bags early, including plenty of diabetes supplies, and the Mums and Bumps have a hospital bag checklist for this. For pump users, change the infusion site the day before your planned C-section or induction so that you don't have to worry about it on the day. It allows enough time for you to work out that the set is working, but it maximizes the time before you have to do another site change with a newborn. If you're having a C-section or being induced, make sure that your pump site and CGM are away from the surgical field, just in case you do end up having an unplanned C-section. Labor increases the risk of hypos. So it's a lot of work for your body, even if you don't realize that you're doing it because of the epidural. Your body is using glucose at a faster rate. Around 56% of women experience a hypo during labor, so be prepared. And it might help you to use similar strategies during labor as you would for exercise. So whether that's a temp target, a temp basal, or an ease up mode. Our to-do list. So we want to stock up on a variety of easy to eat snacks for your hospital bag. So include both fast acting and slow acting carbohydrates, depending on what your blood sugar levels are doing. Here is our list of references. So thank you so much for listening to our presentation. If you have any questions, please feel free to send them through and we'll answer them as soon as we can.